like to, before I get going, thank the Department of Urologic Sciences for keeping these grand rounds going during these strange times. Always a good chance to learn about something new. And special thanks to Dr. Harriman, who's the faculty point person for this topic. Now, the topic I chose to talk about today is SARS-CoV2, or COVID-19 as the clinical syndrome is called, in kidney transplantation, with a special sidebar on the immunology of the disease and how it can inform how we think about transplant and the disease as a whole. Now, as you all know, SARS-CoV2 is a novel coronavirus that arose in Wuhan, China in December of 2019 and causes a severe respiratory illness. This is it rapidly spread worldwide, prompting the World Health Organization to declare a pandemic on March 11th, 2020, and has really posed some unprecedented public health challenges for governments and healthcare systems around the world. Here in BC, we've been, I think I would say, pretty lucky. A combination of timely and appropriate public health interventions have allowed us to weather this storm fairly well. And as Dr. Gleave mentioned, we're doing better than even many of the other provinces across the country. This being said, as you all well know, as part of the public health initiative to stem the spread of COVID-19, operative interventions have been severely limited in BC. And the renal transplantation program was effectively put on hold. And while, with limited data and lack of clarity about how this was going to play out, it was probably the best decision we could make at the time. But as we accrue data and we kind of have a little more hindsight now, I think it is important to scrutinize these kind of decisions and really try to find the point of equipoise between the uncertain risks that COVID-19 poses to our patients and the harms associated with delaying often life-changing or life-prolonging therapies. And this is not just in transplantation, but in every domain of medicine. So, with that kind of overarching principle, I'm going to jump in and tell you a little bit about what we're going to talk about today. I'm going to start by giving you a background on the virus, a little bit of virology, and then I'll talk about the epidemiology and clinical features in immunocompetent patients before moving on to transplant patients. And as a last point of interest, I'll talk about the immunophenotype of COVID-19 with a special focus on what this means in transplantation. So we'll start first with a little bit of biology. SARS-CoV2 is a coronavirus of the genus beta coronavirus. These are enveloped, positive sense, single-stranded RNA viruses that typically affect mammals and avian hosts. It's the 7th known coronavirus to infect humans. There are 4 of them that cause a mild seasonal illness, and then 2 other ones, SARS-CoV and MERS-CoV, which emerged in 2002 and 2012 respectively, which also cause severe fatal respiratory syndromes. And if we look at the phylogenetic tree over here on the right of the slide, SARS-CoV2 is closely related to SARS-CoV with about an 80% sequence identity, falling into the same subgenus of sarbecovirus. MERS-CoV is a little bit different with a 50% sequence identity and is in a different subgenus, merbecovirus. And I think it's important to keep this kind of picture in mind when we think about because we know a limited amount about SARS-CoV2, we often have to turn to SARS-CoV and what we know about MERS-CoV to inform our clinical decision making. Now, the virus, as I said, is an enveloped single-stranded RNA virus, and this just means that the virus's genetic material is surrounded by a lipid bilayer studded by proteins. The proteins are the spike glycoprotein, which has now become notorious. It binds the receptor angiotensin converting enzyme 2 and facilitates receptor-mediated endocytosis. The reason this protein is of considerable interest is it's because this is thought to be the site of the immune response as well. In addition, the envelope has a membrane glycoprotein, which is the most abundant protein. It's structural, and it's thought to help in viral particle assembly and budding from the Golgi apparatus. And there's also an envelope glycoprotein, which is structural and more poorly understood. Inside this envelope, there's the virus's genetic material, and this is a single strand of RNA that's protected by this protein capsid, the helical nucleocapsid. I'm not going to dwell too long on the actual contents of the genome, but there are several open reading frames, which just means points where the virus's genome can be read from. And unlike most other genomes, viral genomes can be read from multiple different start sites, and that's what we see here in the picture. A little bit about how the virus infects cells. As I mentioned previously, the spike glycoprotein binds to angiotensin converting enzyme 2 on the cell's surface, prompting receptor-mediated endocytosis. Once it's been endocytosed, a host serine protease, TMPRSS2, and there's some thoughts that other proteases may play a role as well, like furin, cleaves the viral S protein, allowing the lipid bilayer of the viral envelope to fuse with the endocytotic vesicle and dump the viral contents into the cell. Once inside, the virus kind of hijacks the cell's transcription and translational machinery to produce its components. The viral particles are then assembled in the and Golgi apparatus, and then exocytosed as a virion. So with this kind of with this background, I think it's interesting to think a little bit about what cells in the body are susceptible. And really, until a very recent study by a previous research colleague of mine, Toby Huber, we were kind of guessing. But this is a very nice study in the New England Journal. It's a autopsy study of 22 patients who had SARS-CoV2. And they use RT-PCR to amplify viral RNA from multiple different tissues. And unsurprisingly, what we see here is that the upper and lower respiratory tracts are the most affected sites, but there appears to be a signal in kidneys, liver, and heart as well. They didn't look at the gastrointestinal tract, but there's also thought to be a signal there. They then went on to confirm these findings using in situ hybridization and immunofluorescence. And what you can see here in this panel is the glomerulus or aglomerulus lighting up with these pink virus RNA. This is confirmed by immunofluorescence, where we see spike glycoprotein in green that's kind of hanging out around where the podocytes live. And this shows that there's actually probably a direct renal tropism of the virus, which I think is of interest to us. And I'll talk a little bit more about this later. But what does this actually mean for infection and transmission? Well, if we look at all the various body fluids, our viral RNA can be amplified from a whole bunch of different body fluids. And obviously nasopharyngeal swabs and oropharyngeal swabs, as well as sputum, have been of the greatest interest, because that's mostly how these things get mostly how these infections get diagnosed. But it can also be identified in serum, but although less commonly, stool, which interestingly has the longest life after viral clearance, and semen. In urine, the data is not as clear. There are some reports where they were able to amplify viral RNA from the urine, but some of the larger, better studies looking at this were unable to. RT-PCR positivity, however, does not mean infectivity. Not all these fluids are infectious, and they've really only been able to isolate viral infectious particles from nasopharyngeal swabs, oropharyngeal swabs, and sputum. What the implication of this is that it's most likely simply droplet and fomite transmission with a possible aerosolization, but other routes such as fecal oral, bloodborne, or sexual are unlikely. it's not only interesting, I think, to think about how how the virus is transmitted, but also the timeline of transmission. And what I've tried to do here is, based on a number of different papers, put together a timeline of how we think the virus occurs in a moderately symptomatic patient. So what we see here is that in most patients, there's an asymptomatic period of about 5 days. Within that asymptomatic period, at a median of minus 2.3 days from the onset of symptoms, there's the start of viral shedding. This peaks at about minus 0.7 days prior to the onset of symptoms. This is concerning because these are asymptomatic patients spreading the virus. And it's really thought that the pre-symptomatic transmission, based on modeling from this data, is about 46 to 55%, which is kind of scary. But keep in mind that this is modeling that's occurred in societies where patients who are symptomatic get aggressively quarantined. So one would expect more transmission to occur in the pre-symptomatic period as a proportion. Once the symptoms onset, they typically last for about 9 days, and live virus can be isolated from the upper respiratory tracts and lower respiratory tracts of these patients for up to about 7 days after symptom onset. And this is, again, I wanted to point out that RT-PCR positivity and live virus are two different things. And in fact, while live virus can only be isolated up to about 7 days, RT-PCR positivity can remain up to 20 days after the onset of symptoms, or a median of 12 days after the resolution of symptoms. So now that we have a bit of a handle on the on the actual virology and the biology of the virus, I want to talk a little bit about the clinical features in immunocompetent all-comer patients. Now, this is a list of the symptoms of COVID-19 in by frequency of occurrence, and obviously fever, dry cough, fatigue. These things all make sense. But what I wanted to make a point of in this slide more than anything is that we're still gaining understanding of this disease, and that it's likely that there's going to be a whole lot of other atypical presentations that emerge. And the most recent one is this pediatric inflammatory multisystem syndrome, or as it's colloquially known as, is COVID-Saki, which is a Kawasaki type disease that affects children who are thought to be previously safe from the virus. And really the point I want to make here is that in these special populations like pediatrics, and why not immunosuppressed patients, we may start seeing alternative presentations that are delayed. Now, with respect to outcomes, the data is voluminous and very varied. I undertook, to the best of my abilities, a systematic review of the highest quality retrospective case studies and cohort studies, and I was able to find 11 good, fairly large studies in some of the better journals, The Lancet, New England Journal of Medicine, and JAMA. And while these are high quality journals, it doesn't really mean much because people have been publishing just about anything on coronavirus. The number of patients in these studies varied from 99 to 44,415, which you can imagine is the numbers from China. The populations these studies looked at are hospitalized patients only in 5 studies, hospitalized patients and outpatients in 5 studies, and ICU patients exclusively in 1 study. The outcomes, as I said, are varied. Mechanical ventilation occurred anywhere between 2.3 and 33.1% of patients, depending on which study you look at. And deaths occurred in anywhere between 1.4% and 28.27% of patients, depending on the study. Now, I know this is kind of unhelpful, so I wanted to highlight 2 specific studies that I think are both the biggest and the most inclusive. One of them is out of China, and they look at 44,415 patients. of which 81% have mild symptoms, 14% have severe symptoms, and 5% have critical symptoms, with a death rate of 2.3%. The Italian experience from Lombardia is considerably worse. So and they look at 22,512 patients, while the number of critically ill patients is still 5%, they have many more patients who have a severe course at 24.9%, and a death rate that's markedly higher at 7.2%. Now, this is a bit of a head scratcher. It's kind of like, well, this is the same disease. Why are we seeing such different numbers in these large studies? And I think the answer lies in a couple of peculiarities of how these papers are put together. In Italy, the case definition and the accuracy of reporting is somewhat different than in China and in Russia. In Italy, anyone who is PCR positive for coronavirus and died had a death attributable to coronavirus, whereas that was not the case in China and other countries like Russia. Moreover, the testing strategies in Italy were different. In China, everyone got tested. Everyone was getting CTs and RT-PCRs, and they were able to catch a lot more asymptomatic or post-symptomatic patients. Whereas in Italy, really, symptoms are what prompted testing, and patients with more severe symptoms were more likely to get tested, but also more likely to do worse. And last, Italy just in general has an older population, and we know that older patients do worse. Regardless of what numbers we'd like to pick to follow, if you look at the aggregate data from the World Health Organization, the death rate is about 6.8%. And we really, and I think an interesting exercise going forward is going to be to look at historical mortality data and seasonal mortality data and compare what's happening now versus what's happened to years prior to look at the discrepancy in these numbers. And this may give us a better understanding of how many more people have been dying from this than at any other than at any other similar time in the past. And this will be important, particularly in developed nations where testing will not be as widespread. So now that I've kind of framed the issue, both in terms of the virology and the clinic and the baseline clinical characteristics, I kind of want to move on to focus more on kidney transplantation. And as you all know, the kidney transplant program in BC was held on March 13th, 2020, and resumed on April 24th, 2020, albeit at a much slower rate. And that's a period of over a month. And so what I want to really try to do in this section is to evaluate the risks that COVID-19 poses to immunosuppressed transplant patients and weigh that against the risk of prolonging time on dialysis. So we'll start really here at looking at the clinical data surrounding what COVID-19 does in transplant patients. And there are a number of case reports and case series here that do report on patients who are infected with patients with kidney transplants who are infected with the coronavirus. And these are studies out of the US, Italy, China, and Spain. And I really tried to aggregate them and summarize the data here. There are about 112 reported cases in the literature, 92% of which were hospitalized, 24% of which required mechanical ventilation, and 19% of which died. Now, if you think back to the World Health Organization data, that's of the World Health Organization number of 6.9%, these numbers would appear to be far worse. And it really begs the question, do transplant patients do worse than the general population? And this is a fairly plausible hypothesis if you think about it. These transplant patients are highly comorbid, and we know that patients with comorbidities tend to do worse. And also, transplant patients are immunosuppressed, which at face value seems reasonable to assume that in the setting of a systemic infection, immunosuppression would be bad. That being said, there's some clear data showing that there is a strong immune component to the pathogenesis of COVID-19 that may benefit from immunomodulation. And there's a little bit of evidence in other organ systems, not kidney transplant, that patients who are immunosuppressed may actually fare just as well, if not better. Unfortunately, we really can't tease this question out based on the data we have, but what we can do is we can look at what these case studies here report about the management of immunosuppression empirically when faced with these COVID-19 patients. What did these people do when the rubber hit the road? Now, before I jump into looking at those numbers, I'm going to do a quick primer on transplant immunosuppression for those of you who don't look at these drugs every day. Now, I divide transplant immunosuppression into induction and maintenance. Induction is typically done, at least here, with ATG, which is a rabbit anti-thymoglobulin, a polyclonal antibody against T cell clones. And this is kind of, I'd like to think of this as akin to a nuclear bomb that just indiscriminately destroys all T cell clones. And then there's basiliximab, which is an anti-CD25 antibody. This is the IL-2 receptor, which is important for T cell expansion. And then there's maintenance immunosuppression. This is done with a combination of anti-metabolites, which block de novo purine synthesis, calcineurin inhibitors, which block IL-2 production, and prednisone, which of course is a steroid. So when we look at the data from those case reports and case series, what emerges is that there is really no systematic approach to managing immunosuppression. What I did see was that there was no change in 22 of the patients, no change at all to the immunosuppression. That's 19% of patients. And this is interesting because it does kind of imply that we can manage patients with COVID-19 without altering immunosuppression. That being said, there's with respect to the anti-metabolites, most patients did get those discontinued at 77%. Calcineurin inhibitors were much less frequently dose reduced or discontinued at 24%. And almost no patients had their steroids decreased. And in fact, many patients actually had their steroids increased. And this is interesting in that steroids, this is interesting in that, as I mentioned, there is a theory that immunomodulation may actually be helpful here. And I'm going to come back to this later once we talk a little bit more about the immunology of disease and revisit this to see if these empiric management of immunosuppression does make sense. The other item I wanted to talk about that may be of concern to patients with compromised renal function is the direct involvement of COVID-19 in the kidney. And as I mentioned previously from Toby Huber's work, there was a direct renal tropism for the virus. And this is a publication hot off the press from Jason that shows that there probably actually is a COVID kidney syndrome. And this is characterized by hematuria, proteinuria, and AKI. Now, I know it's tempting to say, well, these patients are critically ill, they develop an AKI, that's like totally normal, and that's fair. But what's more concerning is the hematuria and the proteinuria. This would imply a specific glomerular event. And in fact, many of these patients don't recover from their proteinuria, suggesting that there may actually even be a long-term damage. Now, to me here, the interesting unanswered questions are whether or not patients with CKD or transplant patients are at higher risk of renal involvement or worse renal involvement. And this study tries to get at that by looking at baseline serum creatinine and shows that it's not a predictor of recovery from kidney injury. That being said, I think there's several other dimensions here that need to be explored. Now, the other question I think is, do patients with CKD who are often on immunosuppression or transplant patients who are on immunosuppression fare better or worse? And unfortunately, they didn't stratify any of these patients by whether or not they were on immunosuppression. So now that we've really looked at the two threats facing transplant patients or patients with end-stage kidney disease, looking to be transplanted, namely immunosuppression in the setting of the virus and direct renal involvement of the virus, I'd like to take a look at the flip side of things, which is the risk of prolonging time on dialysis. So here are some Canadian numbers showing that over the last 10 years or so, the number of Canadians on the transplant waitlist has remained more or less stable. So you'd think that would be great. The only problem is we've been doing a lot more kidney transplants. So when we put the transplant program on hold, we're really compromising our ability to keep the transplant waiting list within reason. And we're not the only ones who've done this. So there's a nice paper in the Lancet looking at how France and the United States have responded to the coronavirus epidemic for transplantation. And as you can see here in the top panel, the French really dropped their transplant volume as the number of COVID-19 cases arose. Interestingly, kidney transplants, obviously the hardest hit. And this is probably because kidney transplants are the highest transplant organ, and we have hemodialysis. In the States, the data is less dramatic, but of course, the US's response to the coronavirus has been less dramatic in general and less coordinated, but we can still see a trend here where we have a decrease in the number of transplants that seems to affect the kidney transplants preferentially. Now, the concern here is that by delaying transplantation, there's a negative implication for the health of our patients. And we often quote the abysmal number of 50% mortality at 5 years on dialysis. And I think it's tempting to say, well, this is a drama that plays out over years, not months, and delaying the transplant program a couple months isn't really going to make a difference. Unfortunately, the data doesn't really corroborate that. And this is a really nice paper out of the Department of Nephrology here, the transplant group here, looking at living donor recipients stratified by time on dialysis. And what the data here shows is that if you preemptively transplant patients, they do far better than if you transplant a patient once they've been on dialysis, which are all these lines down here. And this is with respect to living donor transplant failure from any cause, including death. But what I think is more interesting is if you look at the data of patients who do get started on dialysis, patients who are started on dialysis and are dialyzed for about 6 months do about the same. But the moment you start prolonging dialysis a little bit longer than that, so here is 6 to 9 months and 9 to 12 months, we start seeing some real changes in living donor transplant failure from any cause, including death. And this would suggest that this isn't a drama that plays out over years, but rather there's a granularity of months here that really affects the outcomes for our patients. And by delaying the transplant program by months, we may actually be having real clinical outcomes change. So now that I'm kind of wrapping up the more clinical side of the talk, I just want to emphasize a couple take-home points. And the first is it remains unclear whether transplant patients are at decreased or increased risk of morbidity and mortality due to COVID-19, although the data would suggest they're at increased risk. Immunosuppression may be helpful in altering the natural history of severe COVID-19 pneumonia, more on that later. And SARS-CoV2 does appear to have a direct effect on the kidneys, the long-term outcomes of which still need to be determined. And all of these risks need to be weighed against the real risks of delaying transplant and how this affects outcomes in patients with end-stage renal disease. So I'm going to switch gears here and move more onto the sciencey side of things. I'm going to talk a little bit about the immunophenotype of COVID-19, particularly as it pertains to transplant. Now, COVID-19, SARS-CoV2, and MERS-CoV2 are characterized by this have a severe course that's characterized by this acute respiratory distress syndrome that shares some immunologic features across all these viruses. And these are lymphopenia, neutrophilia, and a cytokine release type syndrome or a cytokine storm type syndrome. And I think that having a better understanding of the immune contribution to disease may help may help us better understand how to manage immunosuppression in our transplant patients. Now I'm going to take you guys back to your medical school basic science classes, and I'm going to review a little bit about what a normal immune response to a pathogen looks like. And the take-home point is really there are a couple of different flavors of the immune system based on which pathogen it meets. But in brief, a given pathogen encounters an antigen-presenting cell, and based on conserved molecular patterns, directs the antigen-presenting cell to stimulate naive or undifferentiated helper T cells based on antigen presentation and a co-stimulatory signal to differentiate into different polarizations of the immune system. And these are your classic T helper 1 response, T helper 2 response, and the more recently discovered T helper 17 response. What really pushes the differentiation in a particular direction is the cytokine milieu. And what we see here is that if we push differentiation towards T helper 1, we're telling the immune system it needs to fight off intracellular viruses and bacteria. And this is kind of more of a macrophage CD8 positive T cell type response. T helper 2 is more geared towards parasitic organisms and is more of an antibody mediated response where we get activation of B cells, eosinophils, and mast cells. And T helper 17 response is more of a I like to think of it as a general tissue inflammatory response with marked neutrophil activity. If we look at mild clinical courses of SARS-CoV2, MERS-CoV, or SARS-CoV and MERS-CoV, as well as COVID-19, what we expect to see in a normal, well-regulated immune response is a robust type 1 interferon antiviral response, so activation of these interferon polarizing signals here, followed by differentiation of the corresponding CD4 positive T helper 1 cells, which then activate these CD8 positive T cells, which result in viral clearance. Unfortunately, this can go haywire, and that's what we see in the more severe clinical courses. I'm first going to talk a little bit about the cytokine milieu. Now we have data from previous coronavirus ARDSs that show that SARS-CoV and patients with SARS-CoV and MERS-CoV with severe ARDS have extensive neutrophil and macrophage infiltrate in the lungs, which are causing damage. There's some thought that a hyperinflammatory cytokine and chemokine milieu plays a role in recruiting these effectors. In SARS-CoV, the flavor of the immune system tends more towards a T helper 1 type response with interferon gamma, IL-2, and CXCL10, which is a chemokine for CD4 positive T cells, or CD4 positive T helper 1 cells. There's also expression of some neutrophil and macrophage or neutrophil chemokines here. In MERS-CoV, the picture is a little more blended, and we see the immune system kind of swinging between this T helper 17 flavor, which is characterized by the production of IL-6 and IL-17, and the interferon gamma response. What I mean to say by all of this is that even though these are closely related viruses, they clearly do different things to the immune system. So what do we know about COVID-19 in this respect? Well, there are 6 papers that examine the cytokine milieu in COVID-19. 4 of them look at mild versus severe disease, and 2 look at controls versus cases. The quality of the data is really hampered here by variability of cytokine panels and small numbers. But what we see here is that we see a T helper type 1 signature that is quite robust, and we see a T helper 17 signature that's quite robust with some features of a T helper 2 response. Well, this is actually quite confusing. In parallel, we see a massive production of neutrophilic chemokines. And really what I would take home from this is that we see a strong T helper 1 and T helper 17 signature. And these chemokines are likely to play a role in really jacking up the number of neutrophils present and tissue damage. Now we know that what we see in these chemokines and cytokines should translate to a cellular phenotype, because really these are the signaling molecules that orchestrate the cellular immune system. And the first observation I'd like to make here is that there is in severe cases, we see marked lymphopenia and neutrophilia, even compared to moderate cases. And you can see the data here. Gray is the normal range. These gray bars here represent all patients. But if you compare severe cases to moderate cases, there's many more neutrophils, peripheral neutrophils. In parallel, the number of lymphocytes in severe cases appears to be lower than in moderate cases, but across the board, lymphocytes seem depressed. And if you take a more focused look at these T cells, or at these lymphocytes, we see that they preferentially affect CD4 positive T cells and CD8 positive T cells, which are really the T cells we need to orchestrate our attack against this virus. Now, this seems paradoxical. Why do we have a lymphocyte count that's down in a severe viral infection? And there's a couple of hypotheses here. The first is that there's direct action of the virus on these lymphocytes. And there's really no data to support this. The other concept at play here is pyroptosis, where an aberrant cytokine or chemokine environment causes overactivation of a T cell and apoptosis. In parallel to this, or the corollary of this, is also that these chemokine and cytokine overactivation can cause abnormal activation of these T cells and exhaustion of the stem cell pool, which then fails to be able to mount a more potent T cell response. And there actually is some data to show that this is the case. And I've stayed away from presenting it because it's preprint data and it's quite a bit of a deep dive into T cell biology. And the last reason that this could be the case is that really we're sampling peripheral lymphocytes here, and all of the lymphocytes have migrated into the tissue to do their job. And there's some data from autopsy studies that supports this as well. Regardless of what the cause is, it's clear that depletion of T lymphocytes and neutrophilia may have real prognostic implications. And this is a very nice study in JAMA Internal Medicine, where they took 72 input variables and used machine learning to identify 10 prognostic factors that would predict a severe clinical course in COVID-19. And what they show is that neutrophil to lymphocyte ratio actually has prognostic implications. With this in mind, one would think that therapies that target the overactive Th17 and dysregulated Th1 response may be beneficial. So with this in mind, let's go back to look at how immunosuppression was managed in our transplant patients. And I'll bring you back to this slide that I presented earlier, where we said 19% of patients had no change. And then we had these patients down here had some form of change to their immunosuppression. If we think logically about what we know about the immune response and what these immunosuppressants do, we can probably weigh in on this. ATG induction, as I said, indiscriminate nuclear bomb that kills T lymphocytes, probably bad in the setting of severe T lymphocyte depletion. And in fact, in the states where ATG induction is really the standard, what we're seeing is that they're moving away from this. This is really a change in practice patterns. Antimetabolites block de novo purine synthesis, and T cells rely on de novo purine synthesis because they can't use the purine salvage pathway to differentiate and be produced from stem cells. So we're really blocking the basic building blocks of T cells here. And it's probably not a good idea given that we need to produce more T cells. And in fact, many of these patients have their antimetabolites stopped. Calcineurin inhibitors, which we say block the production of IL-2, is a little more nuanced, I think. You know, we said IL-2 is a feature of the cytokine release syndrome, and I can see a role for blockade of IL-2 production in damping the cytokine release syndrome. And in fact, fewer patients had their calcineurin inhibitors stopped. And last, steroids have a broad immunosuppressive effect with down-regulation of inflammatory gene transcription, as well as inhibition of neutrophil and macrophage function, among many other things. And it makes sense that in a disease where neutrophils are the damaging cell, steroids would be helpful. One other thing I'd like to talk about before moving on from immunosuppression is IL-6, which, as we said, is a Th17 polarizing cytokine. And what I think this is a very exciting piece of data, because it's become very clear that patients with COVID-19 have elevated circulating IL-6, and this is data from an Italian group. What I think is more interesting is we have a monoclonal antibody against IL-6, which is tocilizumab. And there is a French trial which is going to be published soon, which apparently has some promising data, as well as this Italian preprint data here that I've put up that shows that tocilizumab may be helpful in reducing risk of mechanical ventilation and death in these patients. Now, what does that mean in transplant patients? Well, I'll take you back to the case reports and case series that I reviewed. And some of these do report IL-6 levels and show that this correlates with disease severity. 19 of the reported patients did get tocilizumab, but unfortunately, we don't really have anything in the way of meaningful outcome data here. The take-home point from here that I think is interesting, though, is that transplant patients are able to mount a robust inflammatory response characterized by IL-6, despite being on immunosuppression. And I think we can't assume that just because they're immunosuppressed, their inflammatory response is blunted. Before I finish, I do want to touch on a relatively unrelated story with respect to the immune system, and that's humoral immunity. As up until now, RT-PCR, a viral RNA, has been the gold standard for diagnosis, despite this abysmal sensitivity that you see down here. But as the pandemic progresses, what we're going to be moving towards is these antibody tests that detect patients who have mounted an immune response to the coronavirus. And this is going to be a key public health tool in managing the virus going forward, and managing patients infected with the virus going forward. The main question, though, as we begin rolling these tests out, is how do we interpret these tests, both in immunocompetent patients and immunosuppressed patients? In this respect, we can learn some things from the MERS-CoV and the SARS-CoV outbreaks. In MERS-CoV, there were detectable antibody responses in 7 to 21 days after infection, but not all antibody responses, or not all seroconversions, involved neutralizing antibodies, which are the protective ones. What's more concerning is that the titer and duration of these antibodies really correlated with disease severity, with patients who are paucisymptomatic or asymptomatic having no detectable antibodies at 3 months even. SARS-CoV appears to have a more robust humoral response, with a peak in IgG and neutralizing antibodies by 4 months post-infection in most patients. These levels decline but persist in 90% of patients at 2 years. And there's even a small cohort of patients that were followed out to 6 years, in which 2 patients still had detectable IgG, although there was no detectable memory B cell response. I'd like to highlight, unfortunately, that there's no data on immunocompromised patients in this space. We do have some fledgling data in this space in COVID-19. There was a nice Nature Medicine paper that did a detailed immunophenotyping of one patient with mild disease. And they showed that the humoral immune response to SARS-CoV-2 is characterized by antibody secreting cells, so plasma cells, follicular Th cells, IgG and IgM that appear to arise about 7 days after infection. This correlates with a clearance in this particular patient of viral particles by RT-PCR. What this suggests is that in mild disease, the emergence of a specific IgG response coincides with viral clearance. There isn't much more large cohort data, which I think is going to be of considerable interest. But what I was able to find is a preprint in medRxiv reporting on 175 patients with PCR confirmed COVID-19, where they looked at the neutralizing antibody titers measured at hospital discharge. And the picture here is a little more grim, with 30% of patients having very low antibody titers, including 10 patients who are below the limit of detection. This goes to say, again, much like in SARS-CoV and MERS-CoV, the humoral immune response is quite variable. This not only has implications for public health and detection, but also for the development of a vaccine. And this is an area, of course, of incredible interest, with a lot of resources being dumped into this, and 12 vaccines currently in different stages of development. And I think that we're going to have, I think that one of the major challenges is going to be to understand how different populations respond to a potential vaccine, and whether it does indeed confer protection in everyone. So that's kind of the end of the sciencey side of things. I think the real key points here are that severe COVID-19 is characterized by lymphopenia, neutrophilia, and a cytokine release type syndrome. And immunomodulation may be helpful in mitigating this dysregulation. On the humoral immune side of things, the response is extremely variable, and we're going to need to validate these antibody tests in immunocompromised cohorts, as these people are at risk of not mounting a strong humoral response, and vaccine development is likely going to be challenging. In lieu of conclusions here, I think future directions are more warranted because there's so much to learn in this space still. And I think the key items in this space, in this transplant space, that are of interest or going forward are going to be the implications of COVID-19 for the safety of immunosuppressed transplant patients, which I think still remains unclear. I think that the role of immunosuppression is likely nuanced by the type of immunosuppression, and this will, of course, warrant study as well. I would like to point out that in BC, we've tested 2,092 ESRD/transplant patients, of which only 40 were positive and only 2 have died. So the numbers look really good here. Based on this, the VGH Immunology Lab and the Genome Canada Consortium is undertaking a detailed immunophenotyping of these 40 patients, as well as an aggressive prospective data collection effort to try to better characterize what the immune system looks like in these patients and how they do. So with that, I'd like to thank you and for your attention, and I'll take any questions. I have a number of reference slides here that you're welcome to review as well if you want.
Davide, that was a great and timely talk. You did a bang up job on that. It was just fantastic. Does anybody have any questions for Davide?
Hey, can I ask a question, Davide? It's Sam.
Oh, hey, Sam, yeah.
Hey, just a quick question. So with some data that we see that some patients have secondary infections to COVID, would you say in the transplant patient, should they be automatically swabbed prior to having a transplant done to see if they were exposed to the virus? And if so, knowing that there can be a secondary infection, should they be given, should they undergo a further workup, or should they be more closely monitored? How would you basically go about with that kind of patient population that could get a secondary infection?
I think that's a really good question, Sam. And I if we're going to err on the side of caution, what I would say is, as we roll these antibody tests out, transplant patients who have had or who have had an infection with SARS-CoV2 should be tested both with the PCR test as well as the antibody test, which will inform us about whether or not they've mounted an immune response. And I'd like to highlight, though, that having mounted an immune response and even having detectable antibodies that are not necessarily neutralizing antibodies mean that it's not necessarily they're not necessarily protected from SARS-CoV2, and that should they develop any symptoms that are suspicious, they should be retested with PCR. Now, would also like to point out that we don't really know exactly how all of these patients will present, and they may have somewhat atypical presentations, and we have to be vigilant and maybe a little overly cautious with retesting.
Great, thanks.
Davide, Peter Black here. So are you guys doing anything different in the clinical management of transplant patients?
Go
Dr.
for it,
Herman,
Davide.
you might want to cover this, Dr. Herman.
The only thing we're doing different is we are aggressively testing asymptomatic patients in the transplant realm. And we're not just doing one test, we're doing at least 2 tests to try and increase the sensitivity and specificity for COVID. And we're not doing any antibody testing as of yet because that's still sort of in its infancy. But every patient, we're doubling the tests to try and get a better idea of what's going on. That's generally all we're doing differently. And of course, we're trying to isolate patients and keep them physically distanced, as with good measures these days. But that's it.
With your immunosuppression, there's probably not a lot of wiggle room to change too much, but
no, it's. I mean, we're definitely going away from T cell depleting agents because that's clearly going to put our patients at more risk. But the real key is avoiding getting infection altogether in these patients, as with all our patients. I mean, I think it's such an interesting talk because this talk is not really just transplant. It's about everybody. It's this cost benefit of delaying treatment versus trying to do good public health practices. It's a real conundrum. So I totally agree with everything Davide said early on. Shutting things down and trying to get a sense and education on what's going on with this disease is a good idea. And then at some point we got to reopen society and figure out how to live with it.
Dave, I can also touch on that a little bit. Just for the other things that we're doing is we're pre-testing everybody who's coming in for transplant and waiting for their RT-PCR to return before we transplant them. And we're doing a continuous quality improvement on everyone who is transplanted. So we're monitoring whether or not they develop any symptoms of COVID or test positive of COVID at 14 days, 3 months, and 6 months, and what kind of induction therapy they got. Obviously, as you mentioned, we're avoiding any ATG, so patients who require ATG are currently not in our population that we're selecting right now for transplant. And as the CQI, as the quality improvement goes on, we'll start including them if patients are determined to be low risk.
Can I just also ask, do we know if Sweden is still continuing to do transplants or any kind of transplant? Because we know they've been a little bit more relaxed in their measures. So I was wondering if they've postponed certain surgeries, or is there any data to suggest one way or another?
That's a good question. I haven't looked into that. That's probably worth checking out.
I just heard some brief things. I think Sweden gets a lot of publicity because they're in the bars drinking and hanging out. But I think they've been a bit more diligent than just that. I think they have slowed down on a number of things in their population, and I think they haven't been totally reckless as it's often portrayed. But I still think they're continuing to do some stuff, but at lower level, like everywhere in the world. That's what I understand.
Okay, thanks.
Davide, can I ask a question? First of all, that was a really great talk. And you might have steered clear of this on purpose because it's a huge subject area, but viral mutation and what strains are affecting what areas of geography, as well as the studies that are coming out. So sorry if you avoided it on purpose, but I'm just wondering if we're seeing some of those reported different death rates and different immune responses based on different viral mutations. Yeah,
I didn't really look a whole lot into that, but I think the question is interesting. I mean, I think, I was really quick, I think, to attribute geographic differences in mortality to peculiarities of the study and the reporting system. But I think you're absolutely right. We do need to think a little bit about the biology in different places. I know that there is data showing that at least for the antigenic portions of the virus, so the spike glycoprotein, the rate of mutation is relatively low, which is why they think that they're going to be able to make or make a traditional vaccine using the spike glycoprotein as a target. But these single-stranded RNA viruses, as a general rule, don't really have any form of genomic surveillance mechanism, and so they are at risk for rapid mutation. And I wouldn't be surprised if that was the case. Particularly, and you would imagine that we'd see these differences reinforced as countries lock down, as international travel it stops. We would have kind of like a founding effect in different countries, where the virus was imported, and then we can follow the clinical characteristics of the virus and the genomic characteristics of the virus as they play out in isolation. But that's a really interesting space. I did stay away from it, but I do think it warrants some discussion for sure.
I think that's a really interesting question for vaccine development too. How do you combat the different strains, and do you get the same immune responses from each of those strains? And that's totally separate from what we're talking about here today. But it's that's going to be a real challenge in the translational aspects of this issue. Any further questions, guys? It was a really great talk. Lots of comments about how great the talk was, and a question early on about, geez, we should still be doing laparoscopy because chance of transmission there is probably not that big of a deal, which is probably agreed upon by all of us. And it was nice comments and good talk.